therapeutic.
I haven't done the SI for someone
I
let
have.
her help me.
Do I really need this microphone?
You don't.
I probably do.
We'll do each class. Okay, you guys ready?
Yes.
So before we kind of start, what questions do you guys all have?
What's the best?
I can't answer that. I don't know the exam questions.
What's the best way to study for it? Like, what should we focus on when we're studying?
I looked at those tables a lot.
There's,
He really likes these tables.
you know that table that has
Yeah.
all the pluses in it?
Yeah.
Yeah, I know that. That's important.
Okay.
Any, go
Brand
ahead.
generic is pretty important.
Yeah.
Okay,
Remember
yeah.
how to spell them, make a Quizlet, whatever it does. But yeah, whatever you need to do it. And look for trends. All the TCAs have pretty much the same side effects. So just remember that as a class instead of looking at each one like, oh, this one has 4 pluses versus 3 or something like that. Unless he points it out that it's very different than the others, just remember PCAs, dry mouth, anticholinergic stuff.
Okay.
I would say also make sure you know your SIPs and, well, not all of them because obviously the PK graph was huge, but at least the ones that he took the time to put in the slides, those are probably very important. And he will sometimes, I think there might have been a question last year where he kind of played around and said, you know, this medication is a SIP like 1A2 inducer, which one in one of the answers or potential right answers was, you know, fluvoxamine, and you had to be like, no, that's going to interact with the SIP, you can't use it. So just keep that in mind. And the other big thing, which is just like test taking strategy, is if you don't know the answer right away, don't freak out. Just stay calm, read the question a couple of times. Like eventually it'll come to you, and even if it doesn't, just because you don't know the first question, doesn't mean you don't know the rest of them. You probably know a lot more than you think, but as soon as you start to panic about it, you lose your ability to kind of think more rationally, so you would miss things like fluvoxamine in 1A2. And that's just gonna like drop down your score. So, you know, take the deep breaths, center yourself. If you're into yoga, try that. I'm not into yoga because I think it sucks, but not worse than Pilates. Pilates is worse.
How important is it to know, like, diagnostic criteria? Like, you need 3 out of 5 of the, or 3 out of 10 of the following for this diagnosis. You need to have 4 out of 6 of, you know what I mean?
Know it, or like at least kind of have a sense of it, because obviously you can read a case and tell, okay, this person seems depressed, or this person seems to have generalized anxiety. But remember, we're trying to be pharmacists, so generally we are not diagnosing
Right.
patients. So focus the majority of your time on the medications,
Perfect.
but make sure that you know, like,
Right.
in case he does throw in like a trick question on there, like make sure you're familiar with them. What do you think that?
Dr. Sherwood liked that a lot.
Right, Teeter though was more medication. When you get to
Okay.
Sherwood, it's gonna kind of. What happened in our class is most people did well on Teeters and did terrible on Sherwoods, or did well on Sherwoods and did terrible on Teeters. So that is another like factor at play. Is just their teaching styles. Yeah,
Is he gonna ask any questions from the chapter, like maybe throw some random?
I did not read the chapter, and I think I got a 94.
I read the chapter, and I just use it as a way to help me understand the slides, because I feel like he would ramble on about,
Yeah.
like, certain things, but he wrote that chapter, and it's
That's
actually
my
very,
thought, is that's why I want to read, is
it's
because he
very
wrote it.
clear to
Yeah.
me. Like, it was pretty easy to read, so just skim it, even if it helps you a little bit to understand the slides.
Like in the chapter, talks about special populations like the elder, the pregnant. He didn't mention in his slides, so he's not going to ask it, right? If he
Most
didn't
likely
mention.
not.
Most likely not.
That's probably something you look up in practice anyway, so
Right.
I wouldn't worry about it too much unless he really emphasizes on it.
Like it all depends on how you like to study. Like I know a lot of people can read something and understand it. I have a harder time doing that. I like to talk about things. So for most of my therapeutic tests, I sat down with Brooke in our class and we talked through the slideshows, and that's how I remembered most of it. Whereas it was harder for me if I was like just looking at the chapter. But if that's what you like and that's what works for you, then do that. You like, we're in grad school. We all know what study strategies works for us. Any other questions?
About like the scales and stuff of how to assess, like what are the values, like lab values and stuff. Do you have to know
that yet, be familiar. Because generally what's going to happen on this is it's either going to be a specific question, being like which one of these works with CYP1A2, and you'll say fluvoxamine or whatever. Do you know what I mean? It's either going to be a question like that, or it's going to be, so SJ is a 25-year-old white female. She shows up in your pharmacy with a diagnosis of depression. The doctor has prescribed citalopram. You look at her profile and find out she's also on fluoxetine. Do you A, fill the prescription? B, call the doctor because of a risk of serotonin syndrome? C, at least warn the patient to be on the lookout. And it's like, okay, no, you want to call the doctor there because having 2 SSRIs on is not the right thing. You want to discontinue one and start the next. So they're going to be case-based questions at this point, which are more fun. So, yeah.
Can you get serotonin syndrome from SSRIs? Because I feel like there's a ceiling effect with SSRIs.
I think we've learned that you could, especially if you were taking like 2 SSRIs or if you have an SSRI and an MAOI. It's one of those things that you have to keep in your mind as like this big scary side effect that could occur. Like with the lamotrigine is SJS. Does it occur all the time? No, of course not. But it's scary enough that you need to at least warn people that this could happen to you, and if it does, you need to call.
But like if you produce so much serotonin naturally and you're not taking it back up,
Right.
You're just leaving it there. Can you really get serotonin syndrome from that? That's what you're producing naturally, as opposed to having an MAOI with an SSRI, which I can see that being apprehended. That's my question.
I think you can. If I remember correctly, one of the big issues was you don't put 2 people on 2 SSRIs because there's a higher risk, and also you were using the same mechanisms of action.
Yeah, what's the point?
So what's the point?
Oh no, yeah, I'm not saying you should ever take 2 SSRIs at the same time. That's just stupid. But I was just questioning for my own interest.
Or you
It's-
wouldn't do like mirtazapine and sertraline.
Right.
That would be
There was
Yeah,
one
that
though
would
that
be
we
bad,
learned
yeah.
about. What was that?
Okay.
There's one that I don't think it was on our exam or anything. He just talked about it for a long time in class. He called it like rocket fuel, and it was 2 of them, and it was like, oh my god, how do these people not get serotonin syndrome? But like I said, it's a rare thing anyway, so chances are nothing's gonna happen. But I don't know.
Yeah, this is off topic. So
Yeah.
keep going.
One thing I did notice that in the transition from like the middle of P2 year is that everything's pretty much is black and white. Like you had memorization, you memorize receptors, you memorize what this drug does, and brand generic, and you memorize this table. But then you get to those situations where everything's gray, and you have to like make a clinical decision. So you may narrow it down to like 2 multiple choice questions, but you really have to look into the details of the case. Go back through it, see if there's anything that you missed. Even just you leave it for the end and come back to it, so you don't spend all your time on that one question. You forget that you have 15 minutes to answer another 30 questions. So it's kind of fun because it's like a big puzzle when you get the cases, but just read every detail.
If it helps you underline it in cases, because something as simple as, oh, she just got married as a 24-year-old female and is thinking about having kids, that impacts your choices because do you really want to put them on a class D medication that could potentially could give her side effects and like birth defects with her child? No, you do not want to be that guy. Like you don't want to make those mistakes, but it's so easy when you're reading the case just to be like, oh, I don't care what meds is she on, what are her lab values. Don't discount that. Like, make sure that you take the time to read it, because I've gotten questions wrong because of it. I'm sure that you have gotten questions wrong because of it. I got one right because of it today, but that was like a fluke. So, yeah.
Are the plus minuses and the 2 dashes the same thing? Or okay, those are
The ones that I would know are the circled.
Yeah.
So just like citalopram is looking pretty good. Escitalopram is pretty good. Fluoxetine, 2d6, just. Those are just nice things to like have in the back of your mind, especially once you get into more drugs and more of these SIPs come into play, and then you're just like, oh, I guess these 2 things are interacting. But the great news is this is your first therapeutics test, so they're not going to expect you to know like on our test, like if we had lamotrigine and that interacts with the SIP, we would probably be like expected to remember. You guys don't have to do that yet, and honestly, I probably wouldn't remember.
He circled little things.
Right.
tables like this too, so definitely keep in mind what that means. And you can also infer other things, so like a lot of them have metabolites that are active, and looks like fluoxetine has a super long half-life, the only one of SSRIs that has an active metabolite, so you can just keep that in the back of your mind, well, why does it have such a long half-life? It just keeps going.
Anybody know the other like kind of key thing about fluoxetine that makes it a little bit different from SSRIs, or like makes it a certain type of SSRI, I guess? Great, it's the most activating. So that would be great. So if you're reading your patient case and this person comes in and is so depressed and he just doesn't get out of bed and has no energy, you might want to put him on fluoxetine. It's a great choice because it's going to activate you. But if this person like doesn't have that sort of issue and can't sleep at night, you know, fluoxetine might not be your best bet because it is the most activating. You could try something else that maybe won't get the activation. So that's just, again, going into your patient case and deciding clinically which one you think is best. And if we haven't said it, guidelines are huge. Like, SSRIs are obviously your top ones. You can go through more than one. Just because, you know, citalopram doesn't work for them doesn't mean that fluoxetine won't. And if you ever find yourself putting a patient on an MAOI, you probably did something wrong. Because those are not used. Because you're taking a depressed patient, you took away all their wine, all of their cheese, like, just don't go there if you can help it. Like, that's absolute last line. Hi, LKS.
Sorry. Should have kept that for 20 minutes, so that's good.
So far we have just kind of gone through like test taking strategies and how to answer like case questions, which is exactly what you guys are doing in case study right now.
Okay.
So nothing big yet. Everybody good? So next kind of area, what is confusing for you guys right now? If anything. Like what is there a certain like point where you're just like, okay, I really don't understand? Yeah.
Well, I guess probably actually fit that criteria.
Oh, go ahead.
So he said, say you're supposed to pick 3 options for a question, and you pick 2 really good ones, and then you pick bupropion, and that's like a really stupid one. He's gonna take all your points away, so he won't even give you 2 out of 3.
Yeah.
Really? Like he'll really do that?
Really?
A lot of times teachers, if it's a select out of the 5, will not give you credit if you don't get them all.
Let's say maybe that case included they had a childhood history of seizures.
Okay, yeah, I can like
Yeah,
okay.
really.
Yeah.
I think I missed that question. That was the question, I think, that the person had seizures, and you had to be like, oh, you know, bupropion, probably not for you.
Yeah.
You know?
Read the textbook, yes, no? What is
It's
your...
up to you.
Lindsay did it, I didn't. We both did well.
Okay.
It's if you learn from reading, go for it. If you like it, go for it. If you're like me and you learn by talking it through with people, find a buddy. It's whatever works for you.
I tried reading other chapters in the book, like anxiety, and I was way less into it. It was
Other
his
than
chapter
his.
seemed like pretty nice
Okay.
to read. So.
And then that stall book that he talks about, that is great research for you if you are a visual learner. I'm not, so
Do they
I-
have that up at the SASC?
if they don't, I know it's in the library, because I remember I looked at it, and I was just kind of like, okay. But I know, like, one of my friends looked at it, and they were like, what do you mean? Okay, this makes so much sense now, and it was just because, you know, we learn differently.
Right.
Not a good thing, not a bad thing, but it's definitely a great resource and something you guys should check out.
He posted it at one point.
I say, yeah, ours was definitely. It helped a little bit. All the little receptors were shaped differently, so I was like, oh, it has this little receptor. That's nice. But
This is just one picture from Stahl. And it goes into exactly what each receptor does. And on paroxetine, which I found very helpful, it actually has an M1 receptor little thingy. And that is like a muscarinic, it's more anticholinergic, I guess, with that. So it's a little more sedating with other SSRIs. And it could have a little bit more withdrawal effects as well. So if you're really interested, go look at this book. He posted a link somewhere for us. You could ask him to do that for you guys too. So the whole class gets access to it. I think it's free online.
in the second lecture on MDD, there's two pictures, the adrenergic and the serotonergic neuron. He said we can gather most of the information about each of the drugs on there. Can you maybe like go through and
Like mechanisms of action for each one?
like,
Where they go?
does he like focus on that or
I-
More pharmacology. Most of the questions in therapeutics are going to be what is the mechanism of action of this drug.
And the great thing about this chapter is all of your drugs are like called the SSRI, so it's selective serotonin reuptake inhibitor. So it's like, what's the mechanism of action? Well, it's a selective serotonin reuptake inhibitor. Like, so that's kind of great because some of them aren't like that. Obviously, like the tricyclics, obviously that doesn't help you, but some of them are actually really nice. And what I kind of did is if you can relate it back to something. Like for me, knowing that mechanism of action, I was like, okay, so if I block the reuptake, I have tons of serotonin floating around, which is awesome because that plays into how like the current theory of depression, but what is problems with that? And that's what leads you to be like, oh, serotonin syndrome, that's an issue. Because you'll notice that there's some of these like big scary side effects that kind of never leave your brain. Like serotonin syndrome should be one. When you get to lamotrigine, SJS, that should be another. Like they're big things that you need to watch out for because patients can die. And we are like trying so hard to avoid that.
Is that the book?
So
Okay.
Looks like it.
It is available at the library online.
Online?
You have to go down a little bit, it's not listed,
Is
it
that
doesn't come with.
Access Pharmacies?
Yeah, I'll try and post a link.
So does anybody have any like specific questions about the chapter? Or do you guys want to like run through some of the slides and just like hit on what we think is important? How do you guys want to play this? Any suggestion? Yo,
Are we starting with depression, or can I ask a question about anxiety?
go for it.
All right. I'm just confused about the pathophysiology of anxiety.
Okay.
I know we talked about, GABA is important, norepinephrine is important, serotonin is important, but when we talked about depression, we said, in the simplest terms, you'd say there's not enough dopamine, serotonin, norepinephrine. When we're talking about anxiety, can you make any of those generalizations? Because I read that buspirone actually decreases serotonin, and that helps with generalized anxiety disorder, which doesn't make sense because SSRIs help with it too.
So here's the fun part about all of this chapter is if any of you guys watch Grey's Anatomy, there's just so much about the brain that we don't know. So like you look at it, and I think you talked about this in what the class that I was at about norepinephrine, and you're like, this shouldn't work, and it does, and you're like, why does it helpful? So a lot of the times, like the pathophysiology is a little bit grayer than we want it to be, but it's because it's the brain, it's so complex. So my best advice for it, can you find it? Just generalizing, or generalizing anxiety patho. Hold on. It's on there. Isn't it upregulation of the Right. So under our anxiety disorders, at least that whole pathology of it, it's not well understood. So it's gonna sound like a cop-out answer, but no one really knows yet what happens. Like you could say, you upregulate your HPA axis. It could be something to do with GABA or norepinephrine or serotonin. It's probably something to do with all of them. We just don't know yet. But we do know that's why if you take you can take SSRIs for it, and you can take these drugs, so we know that they help. We're just not sure why they help, which is kind of a crappy answer, and I'm really sorry.
No, yeah, I'm just confused. Thank you.
Did I help at all?
No, yeah, definitely. I was just wondering if I was crazy. And
No.
I'm thinking, is he like other professors where he kind of has favorite drugs? Or is he sort of, I feel like certain professors have favorite drugs.
Some
They're gonna
professors
come up,
definitely do.
Um,
He hates one of them, isn't it?
yeah.
Which one did he?
He doesn't
Yeah.
like Esperanto.
So that's the main thing about him is he does not like that drug. In our class, he basically called it placebo. I'm not sure if he did it in your class, but in our class at that point in time, he was like, and this drug is, he just made fun of it for 5 minutes, and then we moved on with class. So I would if you see that option choice, probably don't go there. because he doesn't like that one. But then again, you know, if everything else is wrong, that's, you know, it is an option. You can obviously try it. Like you guys know as well as I do, placebo effects are real things.
One thing I do remember is that OCD is mostly serotonin for drugs, but I think GAD is pretty much whatever works.
It's, yeah.
So there is a slight distinction there as far as what drugs they use, but really it is patient specific with these. You can't really go in their brain and ask it what's going on.
So we just know that those three neurotransmitters are norepinephrine, serotonin, and GABA are messed up. We don't really know in what sense.
In my mind, I kind of think of it as they're out of balance.
Yeah.
Because that kind of makes sense to me. And with something like anxiety, just because it's that constant worrying, isn't it like more days than not for it's a certain length of time? It kind of seems to me, and this is just kind of how I thought of it, was you get all those like neurotransmitters out of balance, and then you just create this loop. And that loop just kind of keeps going on, and that's why you get this like excessive anxiety all the time, because that loop just won't shut off. It's like this positive feedback loop gone wrong. But like I said, that is not in the chapter, so that's just kind of how I thought of it, because it seemed to make sense to me. So if you can do anything to kind of break that loop, whether it's with the serotonin, norepinephrine, whatever you want to try, that's why it kind of shuts off. And that's how it made sense to me, but that's not supported by literature. That's just like, in my world, that's how it works. Until I get new information. Then I'll readjust. Did that help anyone? Okay. Any other questions? Yeah.
So in the depression slides, there's a couple slides that are tables of the drugs with different values and pluses and minuses. Should I just kind of know the general, like, if there's a lot of pluses, remember that, or if it's low, or...
If
He kind of
it's a
said it's
table,
for
if
our
it's like,
reference.
is it that one?
Yeah, he said it's kind of for our reference, but we should also know it. So just know what he circled and pointed out, or...
Know what he circled and pointed out, and it can help you. It helps me a lot just to kind of think of it that way, because if you look at it and you see a side effect like seizures with the bupropion and all those, you know, that's something you want to know, because it's so easy for him to say, oh, and this patient has epilepsy in a case, and it's like, okay, immediately you were not going to use those drugs. So that chart, having that committed to memory, helps you make those clinical decisions.
But mainly the circled parts.
But mainly, yeah, definitely know the circles. And like, for some of them, you don't have to know them all. Just look at the tricyclics and realize, wow, you know, they all have anticholinergic effects and sedation and hypotension and conduction abnormalities.
Okay.
So you can go kind of class by class, but maybe like in that one, like you could look at it and say, okay, so the worst one is for the orthostatic hypotension is the last one, that imipramine. So that might be good to know. So if you had to pick one, at least don't pick that one. But I just went by, this is a class, this is what they do. I'm going to avoid them in these certain cases.
Okay.
Or like there's some of them, maybe you could use them. If the person's not sleeping at night, having something a little bit sedating, that's not a bad thing. Does that make sense?
Yeah, that answers my question.
Then I think we find special populations. What population would you not want to give a tricyclic to? In general, with all those side effects, you don't want them to fall or anything like that.
Elderly. Any special populations you don't want to give in MAOI to?
Everyone.
Good. Trick question. All of them. Never, just don't give those. They're not fun. The selected ones might be okay because then they can still have wine and cheese, but no, like, I don't know. For me, it's like the MAOIs as a class, I was like, you know, probably not, because they're kind of really dirty drugs, and you're having a depressed person, and if you're depressed, you know, I would probably want a glass of wine or cheese or chocolate, and it's like, actually, you can't have that anymore. It's gonna take 6 weeks to work, so you know, good luck to ya. Like, no. Find it. There's better drugs now. We don't need to resort to that anymore. So any other questions? So what would be most helpful? Do you guys want us to go through some of the patho? Do you want to talk about some of the meds? Which way do you want to go?
Give us something, let's talk about the stuff as if it was on an exam.
Okay. So do you want us just to ask questions?
or we can go through the slides and say this may be multiple choice, or this might be in the essay, or I missed what the first 20 minutes. I don't know if you talked about the structure of the exams.
Not much besides saying, you know, be ready for case type questions, and as far as diagnosis, make sure you know it, but it's not as important as knowing the drugs because we want to be pharmacists, not doctors.
Okay.
But that's not to say that it won't be on there. Obviously, if you read a case and it's like, this person seems to be in relatively good spirits, and you know they don't report being sad, and they have low scores in all the scales, and it's like, what antidepressant do you want to prescribe? You're like, no, I do not want to give them one at all. They are fine.
Okay.
Like, you know what I mean? So like, at least have a general picture in your mind of this is a depressed patient.
Okay.
Common symptoms, like biggest things. Like anybody know black box warning for all the SSRIs? Suicide. It's huge. You need so if a patient comes in and they're on fluoxetine for the first time, you need to make sure to tell them, hey, you know, this medication, it could, if you start having like suicidal thoughts or anything like that, you need to tell us. Because it's probably not you, it might be a side effect of your medication. And you don't, like, if you need to at least have them on alert for that so that they're not just like, you know what, this medication does not work, you know, I'm done, it's over. Like, you don't want that to happen to them.
I think Devin had a question.
Yeah.
She had her hand up. You had your hand up.
Oh yeah, never mind.
Is there gonna be essays or is it just like multiple choice?
No essays, multiple
Multiple
choice,
choice.
fill in the blank and match it. I asked.
As I said, generally there's not essays because you can go so many different ways with cases that they want to kind of limit your choices.
Sorry if we already talked about it.
Oh, no, go ahead.
Lab values, that's, I guess, I don't know, my biggest fear. He's tried to alleviate the fear, it didn't really help much. I don't know anything about them really. I can tell you I've got high blood pressure. So,
And he
gave
gave
us
that
to us.
note.
but then he was like, yeah, they have elevated BUN, but their kidney clearance is great. You know what? They were just dehydrated, so they don't have kidney pot. So, I don't know how sensitive it is on the first test.
I
He'll
don't
give us case
know.
studies with the lab values and you can, and what they're supposed to be, and you can say, oh, that's normal, that's elevated, that's normal, that's elevated, that's low. But
can
I don't
send
know what
him
to
a-
do
I don't
with
know
it.
for sure, but we can send him an email and be like, hey Teeter, what are you doing with these lab values? Because that kind of happened to us in patient assessment too, when they were like, you need to know all of the lab values, and I was like, okay, I'm gonna know them. And then there was like one question on them, and I was like, I just wasted like 6 hours of my life doing this, but it's more a patient assessment. But let us check.
Not really, because you have to know them for therapeutics.
Right. You have to know them eventually, and it's good to at least have in mind, like, okay, the UN is related to what?
Correct.
Like, yeah, your senior creatinine. So it's nice to know, because if one of these drugs says, oh, hey, you know, I'm 90% renally cleared, and you calculate that their creatinine clearance is like 2, not probably the best drug for them. You guys both had hands up over there.
So, yeah, today he said something in case and was like, the BUN is greater than the creatinine, like over the max creatinine, something like that. So, like, is, yeah, the ratio of something, and it means this. And everyone, no one said anything, but I feel like we should have. Because I don't, like, we're not supposed to know what that means, right? You can just ask him and, like, not do that.
I don't know for sure what he's thinking for the exams because I haven't talked to him about it. Let me email him and I will get the information back to you guys whether or not you need to know those.
Okay.
It is a good idea to have an idea, but, you know, let me check with them.
Because we have no basis.
I'll tell you what Sarah told me, she's a nurse. So she said that if your BUN is elevated but your creatinine is normal, that's more dehydration. If they're both out of range, if they're both out of whack, that's a kidney problem. So if you see just the BUN elevated and not the creatinine, think dehydration. If they're both out of whack, think kidney problems.
Yeah, isn't something
And since he was drinking alcohol, it makes sense that he would
You'd
be
be
dehydrated.
dehydrated,
So you can
exactly.
kinda put all the
Yep.
info together.
So you always look at those two together, and if they're both out of whack, kidney problems, but if just the bun is elevated, then it's think dehydration. So that's how I'm approaching it.
is the number for
You don't want the ratio above 20.
I don't know what the rate, we didn't get into that, she just said if one's normal and the bun's out of, like if creatinine's normal and the bun, think dehydration.
That shouldn't shouldn't worry about that yet. You may see it in patient assessment. They may want you to know it in there.
Yes.
So
That is totally in patient assessment.
Yeah.
Just as a heads up, you will have to know that at some point. It'll probably be right before your final. Because I remember walking into that and being like, I'm going to know all these lab values. It took me a very long time. I needed a 20 to pass, and I walked out and I was like, I don't know. Don't, not to go into patient assessment, but don't, think that's
Underestimate it.
easy. Don't underestimate that course.
Nope.
Because it will come back and, haunt you. Yeah, that one
Yeah, I
comes
hate
too.
that one too.
If you ever really don't like a course, chances are it's going to come right back to you.
As for drugs that are like highly hepatically cleared and then like a liver function test, stuff like that, like what do these know values, or is it just gonna be like okay, they're experiencing, like you don't wanna they'll tell you if you should give them.
I don't know how he has the test set up, but I will send that email and I can get you guys those answers. I honestly I didn't honestly think about it until we walked in and everyone was like, lab values. I was like, ooh, yeah, I don't know. But it would make it would not be what do I want to say? Lab values are very important, and it might be worth knowing them anyway. Just so it's kind of really important to be able to look at your lab panels and say, okay, which one of these are high, which ones are low, because those can lead you to or from different drug choices, like you just said. If your AST and your ALT are super high, that's signifying that liver damage is occurring. Do you really want to give them a hepatically cleared drug? No. You would want to try to find something maybe more renally clear.
So the drugs mentioned, we should know if they're hepatic or renal. Keep
I
note of
would.
that.
What do you think?
I don't know if it mattered for this exam as much, but
Today we didn't talk about, we were going over a guy who had alcohol problems for 40 years, so I assume his liver isn't that great, but we didn't talk about which drugs were metabolized by which.
Because his liver panel was normal for this
Oh,
guy.
his liver was
Yeah, it
normal.
was.
Okay. I didn't
You might
know if
not.
that,
I don't
affected
remember
it.
it being a huge factor for this test,
Okay.
but eventually they will expect you to know that and be able to adjust your plan accordingly.
Oh, here we go.
so of this table, if someone has severe liver impairment or moderate liver impairment, which would you choose? Just going through SIP, oxidation, everything.
Which would you choose or which wouldn't you
Which
choose?
would you choose? What'd you say? Yeah. So it's a different type of reaction. And I think some of them still go through the liver, but it's a different mechanism. So if you're already hitting the CYP enzymes pretty hard with other drugs, say an 80-year-old patient
Right.
that's on a lot of drugs, probably not so great.
But that is how you would try to learn this table. So make sure you know hey, clonazepam. If they're already on a ton of different drugs and you're she just said they're hitting their SIPs and you need something that has kind of a novel elimination, nitro reduction, you don't see that very often. So that could be a very helpful thing. And then the other way to do it is to look at it and be diazepam, it has a parent that's 20 to 50, it goes 50 to 100 with its metabolite and elimination, that sucker hangs around forever. So, you just kind of have to keep that in mind in the back of your mind, okay, these ones are long acting, these ones are shorter, and then you can make adjustments based on those things. Because if it's something like a seizure, you probably don't need a super long acting one, and you actually should be using benzos anyway. But, if it's something like generalized anxiety, where they're this is an everyday problem, having something that's long acting, that might not be a bad thing, it might increase their compliance, especially if it's a benzo and you're trying to taper them off, because they can self-taper like he was talking about in class. Does anybody know what you need to watch out for though if you are tapering a patient off benzos? Good. Watch out for seizures. It makes it a medical emergency if you start seizing. Anybody know the other one that has seizures with withdrawal symptom, a symptom?
Alcohol.
Perfect. So just keep it in the back of your mind, watch it. I think you can find it or something. Is that the thing? Did you talk about that with you guys yet? The alcohol?
We did alcohol today. Well, we just did the case study. We haven't had the
Slides,
lectures yet.
yeah.
Okay.
No, Monday,
Oh,
Tuesday.
those are fun.
Pay attention to the vitamins.
He loves, isn't
Thiamine.
Yeah, he loves that.
We went into it in great
Banana
detail
bags
today.
are like his best friend.
Yeah.
Give it to everyone.
Yeah.
They all get fried. Like,
There's no reason not to.
right. It's not gonna hurt you.
So he's not tricky, right? So if like he gives you like a little case and they'll be like, which of the following medications would not be a good candidate and why? It wouldn't be like a drug, which is not a good candidate, and the why is like the incorrect reason.
He can do that to you.
Yeah, he does.
But if you like, what I always tried to like to do was I would read the case and I would try to figure out, okay, which drug do I want to use?
Yeah.
You know what I mean? So if I'm reading through the case and like we've done this point before, and it's like, okay, so what drugs do I want to use? Okay, well I'm thinking maybe I'll use fluoxetine. What drugs do I not want to use? Well, he has seizures, so I would like if I had a piece of paper and I would write down like case 1, I'd be like, okay, so seizures, and I put like equals no bupropion. You know, probably no to the tricyclics because they have some seizure side effects. You know what I mean? And then that way, when I looked at the actual answers, I at least had an idea. Because you can sometimes look at the answers and you're like, oh my word, it could be that. And even though before, like 2 seconds ago, you were just like, oh no, it's definitely not. Because that's happened to me before. You just kind of get like,
Talk your way around.
click happy, and you're like, you can talk yourself into answers. Like,
Okay.
try not to talk yourself into answers. Chances are, go with your first instinct. You're probably right. Because every time I change answers, I get this wrong. Especially in therapeutics.
Especially.
You guys have good instincts. You can trust them. Any other questions? Do you want us to like throw you guys questions and see what you come up with for answers? Do you want to go through some of these drugs and like what do you do? Do you want patho? What are you thinking?
So for clonazepam versus lorazepam.
Mhm.
So is an active metabolite like that case you're talking about before? Is that the active metabolite?
It depends. If you
Like what should I get out of this chart?
well,
Just the SIP enzyme, PDI, the alpha.
I mean, they usually extend the half-life, not always in this case, as you can see that alprazolam is still pretty short, even though it has an active metabolite.
He said something about desmethyldiazepam, didn't he? You guys remember?
Yeah,
He
he
said something.
said when you have an active metabolite, you won't have the acute withdrawals, but at the same time you get like accumulation, so you're getting like drowsy the next day.
That was fluoxetine.
like if I was looking at this chart,
That he was talking about.
He said something about desmethyldiazepam. If you see that, you can assume X. I don't remember what he said.
So let's say if there's somebody that's like acutely, they have acute anxiety, so they, every once in a while they just get really freaked out, and they want to take something that's like fast on, fast off, so they're not feeling like shit for a little while. Sorry. So what would you choose from these drugs for that?
so like for me,
Or
or lorazepam. What I would know from this chart, looking like just kind of be able to relate it to things. So if you have a person like she just said, and like I worked with someone at work, and she was like, I don't know what was wrong with her, but she was like scared to death of our boss, which he was a scary guy, but like to the point where she would be taking a benzo when he came into work, like she had a prescription for this. So you don't want to give her something like clonazepam that's gonna take like forever to work. You need something right now. So she was on lorazepam instead. So you have to be able to relate things like elimination half-life. So like lorazepam and alprazolam are short because I don't know. Alprazolam for me kind of reminds me of like a wizard word, like bam, like it's there. So that's how I remember that one was short. I don't know if it helps you. And then lorazepam like raise like you're dead really fast, so that kind of worked for me. But I'm not sure if those help you at all. That's just how like they stuck in my head. But those aren't as great as say you want someone to get off of benzo. You can use these longer ones like clonazepam and diazepam to kind of self-taper. If it has a metabolite, like that can help you. And it, you know what I mean? It depends on which situation you're in at that moment. So it's helpful to have like the working knowledge of the chart so you can see like I'm tapering. I want a long-acting benzo. I need something right now. I need a short-acting benzo. Like, and that's how you use it. Does that make sense to everyone?
Or you have a specific patient that always forgets their meds at home, but is always anxious. You probably want to give them a longer acting one so they don't have to worry about that as much. It's usually patient specific,
can't always justify that in exam questions. So if you have questions after the exam, like I chose this because of this, you can always go talk to the professor, and they'll either correct you or say, okay, I get what you're saying, and maybe give you credit. So
If you do choose to go talk to a professor, make sure you start off with something like "I don't understand," as opposed to "I think you are wrong." They will not help you if you come in and challenge them. Like when you go in, kind of assume that you were wrong and try to get the right answer. Because as soon as you go in and you're like, you know what, I think you're wrong, they're gonna be like, oh no, I'm not. Like, here we go. Whereas if you came in, I think I don't understand, they could tell you why. And so that's what, like I choose to ask it that way. Also, it's more polite. Politeness matters. Don't make the professor mad at you. It just makes it harder for everyone. So that's how like my 2 seconds on asking professors questions. But does everyone kind of get how to use that chart? So if I had a patient and say they had generalized anxiety disorders and you had a doctor and they decided that this person, she has light anxiety, they're going to put them on lorazepam 4 milligrams a day, titrating up the dose to effect, like something crazy high. What would you, like, how would you deal with that situation? Would you, like, call the doctor and say, hey, like, what are you doing? Would you suggest tapering them off? If so, what would you want to use? Or would you want to just, like, so if, say you're trying to taper them off, would you want to say lorazepam and increase the dosing interval? So it's like, okay, maybe take 1 a day, then maybe take it half a day. Or do you want to try to start something like alprazolam and just be like, bam, benzo, and then we'll just kind of go from there? What would you do in that situation? Right, call the doctor. Let's start the tapering, because he can ask you questions like that. Because that's real life practice. You have those doctors sometimes, and you're like, why? Does that make sense to everyone?
He said there's a picture of the brain in here, and he said to know the brain.
This one?
No, like literally a picture of the brain.
Oh,
Is it
like
in this
regions?
slide?
Oh, I don't know.
Yeah, in the slideshow.
It's okay, go ahead.
It was the part 1.
Was it just like the regions of the brain, or?
Yeah. So I'm just unsure of how he would ask a question about that, how it's relevant, because I feel like it's all
not that
case, so
slide
it's
set.
not going to be like, oh, the dial lobe is for movement. You know what I mean?
Well, let me ask, like, how he could do it is you could say, okay, so which part of the brain is highly correlated with PTSD? Anybody know? Yeah, the amygdala, right? It's that intense emotional, like, memory. It's like, that's the part of your brain that's, like, terrified. Like, did any not get, like, raise of hands if you guys read Divergent?
Yeah.
Anybody? That serum that they were giving, that stimulated the amygdala. Like, that was the whole goal. When they were terrified, that's what that was. Because I remember I was doing this class at the same time as reading the book, and I was like, oh my god, this is the same thing. But, so that's how I remember that. But that's how you should kind of know it, so you know those, like, little pathways, or, like, the HPA axis, what's involved in that. And, like, so you can go in and you can say, you know what, the amygdala, that's probably plays a really large role in something like PTSD, not so much in something like depression, because those people, they are just, it's probably more of a balance with neurotransmitters and things like that. Does that make sense to everyone? And how we could kind of ask questions? Because they will ask you questions on, like, patho of diseases. Probably not generalized anxiety, because the answer is, we don't know. But it's easy enough for him to say, you know what, which part of the brains could be elevated in this disorder. Or if someone has, like, depression, are they less likely or more likely to have a substance abuse disorder? What do you guys think? More likely. Anybody know what the number 1 most abused substance is?
Food.
There you go. Thank you, Dr. House Connect. That was her.
It was.
What was it, sorry?
Food.
Food. Yeah. Number 1 most abused substance ever is food.
Available.
It's available. It's not illegal, obviously, because it'd be ridiculous if it was. Like, it's crazy. So does that kind of answer your question, though, about, like, how you could ask questions on the brain? Or what else is related to PTSD? I know it's the amygdala is the one I was thinking of. Is it frontal cortex? What? Yeah. So that's how, like, just kind of, like, it's not something that you need, he's not going to put a picture of the brain on there probably and be like, okay, point to the thalamus. You know, like, which one of these is the thalamus? He probably won't do that, but he could ask you to relate it back to the disease states.
I for sure want to go over that for sure. Talking about the dopamine pathways.
Those ones you do need to know. Parkinson's is a substantia nigra.
Those are a big deal,
Right there.
like how the drugs work and what side effects you get from them.
Whereas in depression, it's more about like the balances of the neurotransmitter, so kind of the area isn't as big of a deal. But like Parkinson's, it is huge, and you need to know. Would you agree or? Sorry. Never mind.
So we talked about like where dopamine, I mean not dopamine, but serotonin and norepinephrine, where they originate. I was just confused about where like dopamine originates, or is that important?
Pathway.
It don't matter.
That sounds right.
That's serotonin.
Serotonin.
One of the drugs.
Serotonin's the raphe nuclei.
It's really hard to remember.
Yeah.
Yeah.
I know, yeah, it's very heavily involved there.
Big dopamines.
Nigra is dope.
Yeah. It is.
So what else, you guys? Like, what else can we clear up for you?
Do you guys have anything with the journal club? Because it's on our quiz next week.
Did we have to do a journal club?
Yes.
I don't even remember.
Leave it as yours.
Capra?
I don't know. It was a different one. It was mostly normal.
Was that rocket fuel thing that I'm remembering? Because there was definitely one or two of them you can put together, and he called it rocket fuel, and it was like, no wonder these pages are on like Cloud9 right now. Like, it sounded insane.
I would just be generally familiar with whatever journal article he gave you. I don't know if it's the same one as he gave us, but know the mechanism of action of that drug and what makes it different than what you've been studying, and how it might help differently.
He's not going to ask, like, for that article, like, interpret this data, like this graph, or what do you,
Probably
something like
not.
that. Okay.
It might just even just be the drug might be in the multiple choice section, and you could choose it as an answer to a case.
Right.
Just
I think we might have had like one question on it, but it was like if you were there in case study that day, you could be pretty confident that you like knew what was going on. Yeah.
How does he keep case study days separate? Because I feel like what he told us on Friday was way different than what I listened to. Like the basics were there, but like compared to what Jody had recorded on Thursday, there was information that he gave them that he didn't give us, or information that he gave us that didn't give them. And I think it's just the way the conversations go. I don't
Yeah.
think it's purposeful. But are we responsible for knowing information in both for the exams? Like maybe something that he said that he's like, oh well, if they were in lecture, then they'll know that. But the people on Thursday won't know any more than
Right.
the people that didn't show up on Friday.
I want to say for our class, he tried to keep it to things that we talked about on both days.
Okay.
Because I know I never went in and listened to the other case studies lectures because I was like, I went to my own case study.
Right. I just wanted to make sure that that wasn't going to be.
I think he's going to try not to.
he's pretty much very much about if someone's interested in something, he'll just run with it. So if someone has a specific question, he'll
Right.
answer that, but he's not gonna hold that to you for the exam.
Okay. Yeah, because that's kind of what I noticed that with different groups there were different interests, so they kind of went different ways.
Yeah.
Right.
Okay.
Because you guys know him, he's this like tall dude. He's excited about everything having to do with the brain. You know, professors, they love it when you show an interest in something that they're talking about, and so they'll want to talk about it with you. But it might not be something that's going to be on the test because it's not fair to hold like if I was talking to like about some rare side effect of fluoxetine with you, it's not fair to hold Jody responsible for it because how would she know?
Right. That's the only thing I was worried about.
Well, I talked to him today, and last week for our case study, we never got a definitive answer of what the medication was. We ran out of time, so we never got the answer. Friday's class did, so I asked him today. He's like, oh, we didn't get that far. Like, he totally didn't realize that we didn't finish that case study. So I would hope he wouldn't hold us responsible for, what the answer was when we never, I actually,
The question on the exam though won't be like, so what was the correct drug choice from the case study? He would actually give you a situation and then you could run with it whichever way you chose.
Okay.
Any other questions and clear up?
Did we ever pass out a sign up sheet?
Oh,
Hold on. So any other questions? Comments? Yo.
In general, is it that hard? I think we're all, I'm terrified, I don't know why. Is it that challenging? Or is it very school
I was saying earlier, I don't know if you were here for it, but therapeutics is a little bit more gray, but they're not going to try to trip you up on purpose. So they may accidentally trip you up, and that sucks. But they'll realize it and give you the points back and explain to you what the correct answer is. But they're going to try to make the questions on the exam as explicit and black and white as they can, so that you can pick out one answer or select all that apply.
So is it so difficult because people find themselves not able to learn in this kind of critical thinking, connecting the dots way?
I think
It's difficult because it's a new way of thinking. Because like in pharmacology, it was straight up into your brain one way, spit it back the same way.
Okay.
And this you're applying what you know.
Yeah.
So that makes it harder, but it also makes it a lot more fun in my book because this is the stuff this is why I wanted to be a pharmacist, was because I wanted to know this. And I will say I was terrified for my first therapeutics exam. I'm still terrified of therapeutics exams, but you get through it, and if you put in the work and you put in the time, it will show in your grades. So you just kind of have to take it with like some faith that, you know what, your instincts are good, you've made it this far, and you guys can do this.
You can't have that exam.
Right. You don't want to be the way my uncle's a nurse, and the way he explained it to me is study for an exam like you're going in the next day, and there's going to be a patient in front of you. Do you really want to be the person who has to stand there and say, I don't know? Because I'm terrified of being that person. So that's how I try to think of it. But on the other hand, you know what? You're in pharmacy school. You're going to make mistakes. It's just a test. So it's something like if being nervous helps you and will force you to study, like it does me, go for it. But it's just an exam. You guys can get through this, and hopefully it'll be kind of fun. Like I loved therapeutics. It was my favorite.
Have you had a quiz yet?
no, it keeps getting pushed back.
Tuesday or Monday or
That
something.
will probably help you figure. I usually use the quizzes. I don't do very well on them. I'm like, oh crap.
I failed tons of them.
Yeah.
There was a person I talked to one time, and I was like, oh, how did you do on the quiz? And she was like, what the heck? I got a 0. I was there that day, and you could see it on her, like, oh, like she just legitimately didn't get any of them right. But you also had your group quizzes, and those bring up your scores, and I'm pretty sure I failed half of them, and I still got an A. So they're there to make sure that you're studying. So if you do poorly on one of them, it doesn't mean you're going to do poorly on the exam. All it means is, maybe you might want to spend a little bit more time with the subject before the exam happens. For me right now, it's Alzheimer's. I need to go back and look at it because I was stumped on those exam questions. So can we just get a show of hands? Was this helpful for you guys?
Yes.
Is there anything we can do next time that could be more helpful? Okay. Do you guys have any interest in doing Jeopardy games and things like that?
Yes,
Okay.
If you
Because
have to make us games, I will play them.
okay.
for sure.
I know that Lefroy was looking into something, so I was just trying to get a reaction, and if that would be fun. Because honestly, I love playing games. I think that they're the greatest thing. But I'm not sure how you guys feel.
I love
Okay, I'll let her know.
Don't forget to sign in.
Please sign in. If you have any questions, feel free to come and talk to us. I think my tutoring hours are 6 to 8 on Wednesdays, which is not helpful right now.
PM?
Yeah, they're late.
Mine are at 8:30 in the morning on Wednesday.
Yeah, mine's already.
And I think I have by appointment on Tuesdays from 12:30 sometime. I don't know, you can look me up.
Emmy and Jang are also tutoring too.
Right, and they're great.
He's not gonna give any other drugs than ones listed here, right?
No. He will stay with. He's not gonna pull something. If you see a drug on there and you're like, I don't know what this is, it's probably not great. Just kind of. That's how I use it.
So just know everything he's listed.